Hi, this is Tom Charlton. I'm the Regional EMS Director for U.S. Acute Care Solutions, staffing the Mercy emergency departments in the greater Cincinnati area. Today we are going to talk about seizures and specifically about some updates to the concentration of Versed that many of us are going to be carrying. So the objectives of today's lecture is to discuss the epidemiology of seizures, the pathophysiology of them, what are initial treatment priorities for EMS, what some of the latest literature is regarding seizures, and then review the Academy of Medicine protocols. So 1 in 26 people are going to develop epilepsy at some point during their life. If you think back to the last year, most of us have probably responded on at least one patient that was either actively seizing or had just stopped seizing and was postictal. So this is a fairly regular occurrence for us in EMS. We know that there really isn't any difference between the genders. It happens equally in men and in women. And it has what we call a bimodal distribution, meaning that it affects the young as well as affecting the folks that are older. And during middle years, there tends not to be as many first-time seizures. So the reason there is this bimodal distribution is when you're young, you're more likely to have a primary seizure disorder, such as epilepsy. And so that manifests itself while you're still young. You get started on medication and other treatments. As you get older, though, you tend to get put on medications. You may develop cancer or tumors that will then predispose you to developing seizures. And we call those secondary type seizures, where they're caused by something other than a seizure disorder itself. What happens during seizures is you get this abnormal and excessive neuron discharge. And so the brain basically turns into a lightning storm and slowly begins to take over the entire functions of it. And seizures will have a wide variety of different presentations, and we're going to watch a video on that here shortly. Epilepsy occurs when 2 or more seizures from an unknown cause occur more than 24 hours apart. So anyone that has a first-time seizure is kind of, you get your one free seizure for your life. And then after that, if you have a second seizure, you may have the definition of epilepsy. There are multiple causes for seizure apart from idiopathic, meaning a primary seizure disorder. So again, what's occurring in the brain? Typically, these will start off as a one focal area that begins to become irritated and eventually then becomes more widespread. So it will start off in one focal area. Sometimes it'll start off in a couple different areas that then begins to slowly take over the brain and leads to this generalized tonic-clonic type activity that most of us recognize from really bad seizure patients that we've had before or from TV and movies. Because some of these seizures will never progress beyond, focal or multifocal seizures, sometimes people will still be conscious during this. They may have very odd behaviors, their speech may be garbled, etc. And that may be an indication of the area of their brain that's abnormally firing. Not all of these focal seizures are going to then progress and develop into full-blown generalized tonic-clonic seizures. Everyone in life has this thing we call a seizure threshold. Essentially, anybody on the planet has the ability to have a seizure given the right circumstances. And there are a bunch of different things that will lower your seizure threshold, making it easier for you to seize. In a primary seizure disorder, these folks' seizure thresholds is significantly lower than it would be in a normal healthy person. However, drugs and other things can lower the seizure threshold, making it easier for you to have a seizure. Some of the things that will do this are hypoglycemia, hypoxia, if you sustain a head injury. Alcohol intoxication can cause it, but so can alcohol withdrawal. Marijuana use, specifically certain strains of it. Stroke, central nervous system infections such as meningitis or encephalitis. We know that febrile seizures occur in younger kids, and we're going to talk more specifically about that later. Pregnant women will also, unfortunately, have seizures if they're eclamptic. You may also get seizures from mass effect, meaning a tumor or bleeding that's putting pressure on the brain that will cause seizure activity. And then also common is some drug toxicity. A lot of drugs that are on the market, unfortunately, do have seizures listed as one of the side effects. And there are a few that we use on a more regular basis that can do this as well, such as bupropion, which is an antidepressant, tramadol, which is a mild narcotic. Both of those have been associated with seizure activity. Before someone has a seizure, they may sometimes develop an aura, and sometimes this will be part of a seizure. This can be auditory, visual, smell, taste, touch. Basically a clue that this person is getting ready to have a seizure. And we probably all have responded on a call before where someone calls 911 and the story is they feel like they're getting ready to have a seizure. And this is what's occurring, is they're getting this aura, this feeling that they're going to have a seizure. Some of the special seizure dogs that are trained in how to recognize this will clue the patient in, even if the patient hasn't yet seen it. The dogs can sometimes pick up on some of these nonverbal cues that the person's getting ready to have a seizure and can help get them to sit down or protect them if they fall. In addition, once they go to the ground, most of them are trained, if it's a tonic-clonic seizure, to climb underneath the patient's head so that the dog essentially begins to act as a pillow for the patient to move their head against. Some patients will also develop this prodrome, which is not necessarily part of the seizure per se. This can mean irritability, mood swings, sleep disturbances before seizure activity begins to happen. There are a variety of different types of seizures. Again, the one that we think of most commonly, if you ask for a prototypical seizure, is the generalized tonic-clonic type seizure. But there's also tonic, there's plain clonic, and then there are multiple different subtypes of partial seizures. And so now we're going to watch a video on what these different seizures will look like.
Miniature spirograph we take in the car when we travel. You know what a spirograph is? It makes little designs. It's like a gear. You put your pencil in holes in it, and anyways, it makes all kinds of little designs. Why don't you guys go out, because the nurses are going to be coming in. Hi. Not a problem. Thanks, Pat. He generally vomits after.
He does? Okay.
Yeah.
Okay.
And he quite often loses bladder control.
Okay.
So.
Why go this way?
Stop you bumping your arms. You bumped your arms on there. All right.
You okay?
Yeah.
You have any more?
No.
It's alright. It's okay. Hey. It's okay. It's okay.
Okay.
I know.
Mom. Mom. Mary. Okay.
Okay.
I don't.
Oh.
Hey, Mom. I'm down too.
Stop these little jerks that you're seeing, and then they start to progress. I can always tell when he's going into a tonic-clonic because his eyes will get real glassy, and then he'll kind of go into like this catatonic state. No, honey, please sit down. And oh boy, of course he just woke.
One, two, three, four, five, six, 7, 8, 9.
Do it the way I show you, like this, Miguel. And where's the plus sign? Miguelito. Miguel. 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 Miguel.
Huh?
What's the plus sign? You need to put the plus sign there.
Even though you're absent, she sent me the homework that when I was
Yeah,
absent.
but do you know what they did, Miguel? Miguel. Miguelito. Okay, so what are you supposed to do today here?
Can you say a knock-knock joke?
Not tell.
Tell Mom a knock-knock joke.
Knock, knock.
Who's there?
Apple.
Apple who?
Boo, boo. Mm,
That is funny.
okay.
Is it my turn?
Now.
I say one? Knock, knock.
Who's there?
Who?
Who?
Are you an owl?
No.
Knock.
No.
Is it, should I do another one?
No.
Oh. Are you going to tell me one then?
Hoo-hoo. No.
Is it my turn to say one? Knock, knock.
Hoo-hoo.
No, who's there?
Seizure. Your right leg's shaking.
Don't like it. It's so cut out. Is that good?
Sit down.
No, it's only I can't see it back. No, I can see it.
Oh no, because your head is right there.
You can cut it off.
Febrile seizures are another type of seizure that can sometimes occur. It's the most common cause of seizures in children. Most kids are going to outgrow this by the age of 6. We know that there's a genetic predisposition because they tend to run in families. And so one of the first questions that I typically will ask is whether or not anybody else in the family has had these type of seizures before. The primary treatment is cooling, meaning you need to get their temperature to begin to come down. And that may mean a cool washcloth or giving them acetaminophen 15 milligrams per kilogram. Most of the agencies around here are carrying this or are going to be carrying this, so we will finally be able to treat these kids' fevers. Typically, a febrile seizure is only going to occur once during that fever. We know that there is some predilection for having a febrile seizure depending on how fast that fever rises. And so it seems to be more with how quickly the temperature develops as opposed to how high the temperature gets. A lot of families that have a kid that has febrile seizures will get told, if you think your kid's beginning to become sick, etc., give them a dose of Tylenol, give them a dose of ibuprofen. That way we can begin to keep that fever under control and keep it from spiking too quickly and developing another seizure. So the treatment priorities for us when we arrive on scene is if the patient's still seizing, we've got to treat the seizure. And we're going to go over why we treat it the way we do. But the initial treatment for adults is 10 milligrams of Versed intramuscularly. If the patient's no longer seizing, they may be back to the normal baseline or they may be postictal. We want to, of course, just do supportive things. Begin working them up, meaning get them on the monitor, make sure they're not hypoxic, check a blood glucose, obtain a history on them. If we're an ALS crew and we're going to be transporting this patient, get an IV in them while you can and keep them on the monitor. And then while you're transporting, you want to transport them with supportive care. Granted, most of our gurneys, etc., don't really have any room for people to hurt themselves. However, if you're in a tighter ambulance where a patient could theoretically hit their head on something, you want to make sure that that area is padded as best you can with some blankets. So then we have the Rampart trial, and I like to use this picture because this is Randy Mantooth, and Randy Mantooth was one of the actors from the TV show Emergency, and anybody that remembers that knows that the hospital that they transported everybody to was Rampart Emergency Department. And so it was kind of funny when this study came out. They clearly designed the study's acronym around the idea of Rampart to pay homage to the role that the TV show had in developing modern EMS across the country. This really was a paradigm shift for EMS and for emergency medicine. And essentially what it showed was that IM Versed works better with less side effects than any of the IV medications that were used. We really don't want to waste our time on establishing IV access. We want to give them an intramuscular dose of Versed first and then work on establishing the IV. And what kind of a lecture would it be when we talk about emergency without us playing the emergency theme song? Brings back a lot of memories for me anyway.
Neurologic emergencies are one of the most common reasons for emergency medical services to be called. Among those calls, about 5 to 10% of all EMS runs are for patients experiencing a seizure.
Prolonged seizures that don't stop by themselves are quite dangerous. About 55,000 deaths per year in the United States are attributed to status epilepticus, to seizures that don't stop by themselves.
To study these and other neurologic emergencies and the best ways to treat them, the National Institutes of Health created the NET, Neurologic Emergency Treatment Trials Network. The NET studies are coordinated by the University of Michigan, with participation from hospitals and emergency medicine providers across the country.
Neurological emergencies is a huge problem in the U.S. and worldwide, actually. And about every 2 minutes, somebody in the U.S. dies from a neurological emergency.
The latest NET study findings, published in the prestigious New England Journal of Medicine, looked specifically at emergency treatment for prolonged seizure.
The University of Michigan is the clinical coordinating center for a multi-center clinical trial that we call RAMPART, which is the Rapid Anticonvulsant Medication Prior to Arrival trial. RAMPART was a study to look at the use of intramuscular injections rather than IV injections to stop seizures in patients who were having seizures that wouldn't stop by themselves when treated by paramedics. The purpose was to see if the IM shots were as safe and effective as the IV injections, but what was really exciting is that we found out that the IM shots were not only as effective, they were actually a little bit better at stopping seizures prior to arrival in the emergency department. It also showed that patients who got the intramuscular medication were more likely to be well enough to be discharged from the emergency department rather than admitted to the hospital than patients that got the intravenous medication. What would happen is paramedics arrive on the scene of a patient who's seizing. They would assess the patient by their local protocols. If the patient was eligible for the study, they would take out a special study box, open it, and the box would contain both an IM autoinjector, which is a rapid way of delivering medication intramuscularly, and an IV syringe. They would give the IM autoinjector and then start an IV. In each case, patients got active medication for their seizures. In half the patients, the active medication was in the IM autoinjector. In the other half of the cases, the active medicine was in the IV syringe. Neither the paramedic nor the patient would know which of the two syringes had the active medication. The implications of this for paramedic practice are pretty significant. This is clearly, I think, an evolution in the treatment of seizures by paramedics. It's not revolutionary, but it's a newer, better way of doing things that I think will be adopted widespread across the country.
Another thing that's relatively new on the market is this thing called a vagal nerve stimulator. And this is a pacemaker type device that sits in the anterior chest wall. The patient then has a magnet that they wear on their wrist. Sometimes if it's a kid, they'll give the caregiver one of the wristbands or sometimes just a standalone magnet. And essentially what happens is you swipe this magnet across the area that this device sits in the chest wall, and it stimulates the vagal nerve. So instead of having pacemaker wires that go down and into the heart to provide pacing, you have smaller wires that will wrap themselves around the vagal nerve. And what the vagal nerve helps to do is it helps to slow things down. And so it provides stimulation to this nerve, hopefully either preventing the seizure from ever occurring or lessening the intensity of the seizure or breaking the seizure if it's already begun. It's already written into protocol that if you come across a person who is actively seizing and they have one of these devices, that you are permitted to activate it. There really is not any downside. It does not hurt the patient. They most of the time will not even be able to tell that anything is occurring. It's not like a defibrillator that's in someone's chest where they're going to get shocked or anything like that. There's no such thing as overdosing the patient either. It's computerized, and so it's only going to be able to provide a certain number of stimulations in a given time frame.
One of the options for treatment of epilepsy is a sort of epilepsy surgery that involves placing a pacemaker. This is called a vagus nerve stimulator. This little tiny pacemaker is placed in your chest wall, and then it has leads that are threaded up around your vagus nerve. And what it does is it shoots electricity up the vagus nerve that controls or helps to reduce seizure activity in the brain by changing the neurotransmitters.
What you have to think of the vagus nerve stimulator as just another type of medication, because we implant this device. We start at a very low setting, and what happens is each month or every 2 weeks you'll go to the neurologist's office, and he or she will adjust the amount of electrical stimulation to help try to control the seizures. This has an efficacy of about 1/3 of the patients, seizures are totally stopped. Right. 1/3 they improve the seizures by more than 50%, and 1/3 it doesn't work at all. So you need to have a conversation with your neurologist whether this is a good option for you.
So again, a vagus nerve stimulator is a pacemaker that's implanted in your chest wall shoots electricity into your brain to cut down on the seizures. The other good thing about this pacemaker is that it comes with a magnet that the person can wear on their wrist or the caregivers can have. And when the patient or the caregiver sees or feels a seizure occurring, they can give an extra swipe of the magnet across the pacemaker, which gives some added electricity and will abort the seizure before it takes place. So this is another option for control of seizures that you can discuss with your neurologist and your neurosurgeon.
So what happens after a seizure? Well, the unfortunate thing is that seizures, if they're untreated, really do cause harm. One of the things we used to joke about somewhat morbidly in residency was about how all disease states eventually lead to seizure, coma, and death. And that's not really necessarily false. Seizures will lead to coma and death. A lot of these generalized tonic-clonic type seizures will lead to profound hypoxia, which then kicks in anaerobic metabolism, which causes acidosis and muscle cells to begin breaking down, eventually leading to cell death. Unfortunately, the longer this occurs, the more brain cells get injured by this or get killed off by this. And so we genuinely do want to stop that seizure as quickly as we can, preventing hopefully further damage to the brain itself as well as the rest of the body. You can also develop significant injuries from a seizure, and unfortunately this can include lethal injuries. There are numerous patients every year that unfortunately seize while driving and get involved in fatal auto accidents, either for themselves or for another driver. Sometimes you can also injure yourself if you seize while doing other things such as swimming offshore or climbing a ladder or doing other things that are unsafe if you seized and lost the ability to control yourself. There's also significant medication side effects from a lot of the treatments for this. Unfortunately, most of the side effects from these medications include drowsiness or sleepiness. Sometimes it can cause personality changes. Some of the medications that are older also will cause liver and kidney damage and sometimes will cause tooth problems. And so these are not necessarily benign medications. And unfortunately, it can mean that we sometimes have to try different kinds of medications until we finally get something that is going to control the patient's seizure, but at the same time not be over-sedating or have too many other side effects. There's also this time frame immediately following a seizure called the postictal period. And it's really important for us to differentiate between a postictal period as well as continuing seizure activity. Unfortunately, sometimes patients will still be unconscious after they've stopped with their generalized tonic-clonic behavior, but they may still be having seizure activity. And that may manifest itself with something as simple as their eye is twitching, or they're doing lip smacking, or they're moving one small portion of the body. And that can all be indications that this person is not actually postictal. They're just continuing to seize. However, it's not as widespread as it was previously. A postictal period I like to liken to your brain rebooting. And you need to not think of the brain as a bunch of, as one big computer. It's more like a bunch of computers that are on a network. And each one of those computers reboots faster than the others. So that means that certain areas of the brain will become active before other areas of the brain have completely recovered and are still kind of spooling up. As a result, these patients will sometimes have all kinds of weird presentations, including sometimes being violent, confused, combative. Sometimes they'll have paralysis. Frequently, regardless, the patient is going to be somewhat sleepy. And the reason for this is their brain has essentially just run a marathon. It burned up lots of energy, used up lots of neurotransmitters, and so the patient typically is going to be extremely fatigued and likely be somewhat sleepy. There's also this thing called Todd's paresis, which I'm going to show you now. So you can see here, this person after their seizure is not able to really completely raise their hand up. They're able to lift their left hand up fine, but they cannot really move their right hand very well. This is a rather mild case of it, where the patient is still able to somewhat use their hand. It's just not quite as functional. I've seen cases where the person is literally paralyzed on one side of their body, and it looks as if they've had a massive stroke. That's also one of the reasons why a lot of the checklists for us to give TPA, the clot-busting drug, will include seizure. If someone has had a seizure before their stroke-like symptoms began, that gives us a little bit of a pause as to whether or not this truly is a seizure or is a stroke. And if we have any suspicion that this is a seizure and not a stroke, then it's relatively dangerous for us to go ahead and treat them with the clot-busting drug. So what's the Academy of Medicine protocol? Well, it's mirroring the Rampart trial. For adults, we want to give them intramuscular Versed, 10 milligrams, if they're actively seizing. Otherwise, if we've already got an IV in them, then we want to give them an IV dose of it. And we're going to do it at 2 to 4 milligrams per minute to a maximum of 10 milligrams. And so that's going to take us anywhere from 2.5 to 5 minutes to get the maximum dose in, depending on how quickly we're infusing the medication. It is still acceptable, however, if you have an IV, to give the medication intramuscularly still. And the reason for that is because we know that there are fewer side effects when it's given intramuscularly. There was a recent trial that was just published a few months ago that showed that one agency where its paramedics were somewhat concerned about giving the higher doses, they wanted to see what the outcomes were like between patients that received the full 10 milligrams intramuscularly versus 5 milligrams, potentially followed by another 5 milligrams. And interestingly, the patients that received the full dose right off the bat were intubated less frequently, admitted to the hospital less frequently, admitted to the intensive care unit less frequently, had faster resolution of their seizure, and also faster discharge home. So it was essentially mirroring the Rampart trial, where it was better to give them the full dose than it was to give them the smaller half doses. And part of the reason behind that is the longer the seizure goes on, sometimes the harder it is to break. And we may initially need that full 10 milligrams of Versed intramuscularly to get the seizure to break. And by breaking the seizure earlier, we are allowing that patient's brain to have not gone through quite as much trauma and workout as it would have otherwise. Once we have given them their Versed, we want to make sure we check their glucose, support their respirations. That may include putting them on end-tidal capnography so we know exactly how well they're breathing. If they're pregnant, we want to also consider giving them magnesium sulfate, 4 grams intramuscular, and transporting them to an OB center. And the reason we want to transport them to an OB center is because a pregnant female that is seizing, that otherwise does not have a seizure disorder, is likely going to be eclamptic and will need an emergent C-section to resolve things. Kids are relatively simple as well. If you have a small kid that's, say, less than 30 kilograms, you're going to give 0.2 milligrams per kilogram intramuscularly. If you've got a medium-sized kid that's basically on the long end of the Broslow tape and above, they're going to be getting 5 milligrams intramuscularly. And then anybody who kind of reaches the point where they're a little adult, we're going to give them the full adult dose of 10 milligrams of Versed. So small, 0.2 mg per kg, medium, 5 milligrams, large, 10 milligrams. So now we're going to be carrying a new concentration at some departments. The prior concentration that Sharonville at least was carrying was midazolam 5 milligrams per 5 ml, which is 1 milligrams per milliliter. And we need 10 milligrams to be given in order to treat this. Unfortunately, that means that we have to give multiple injections to give it with the existing 5 milligram per 5 ml dose. Unfortunately, you're only able to administer about 2 to 3 cc's of medication into a large muscle group before you then have to switch to a different muscle. So realistically, this would take us from 3 to 5 different injection sites, depending on the size and dose of medication we were going to need to give. Obviously, that's not ideal. So we needed to get to a more concentrated solution. And so the most common concentration that we will use for intramuscular injection is going to be this 10 milligrams per 2 ml or 5 milligrams per milliliter solution. And this makes life a little bit easier for us as well, because now we've moved from the adult dose needing to be 2 vials to now the adult dose is 1 vial. So for an adult to get 10 milligrams of Versed, you're going to draw up 1 entire vial of the midazolam. If you have a medium-sized kid, you're going to draw up half or 5 milligrams or 1 ml. And then if you've got a kid that is on the smaller end of things, then you're going to do the weight-based, and so it's going to be less than 1 milliliter. Again, this is safe to be given intramuscularly. However, you can also give it intravenously if you already have an IV established when they begin to seize again. So as always, if you have any questions, please feel free to email me at the above email address. That concludes the portion of this that deals with seizures. However, I do want to also talk about sedation, since we also will use Versed for sedation. So I'm going to pull over the Academy of Medicine protocols. So this is the Academy of Medicine protocol that deals with sedation. And you'll see here under chemical restraints, we're going to administer midazolam Versed 5 to 10 milligrams intramuscular or intranasal based on weight and agitation. Exposure and cleaning of the skin is highly recommended but may not be feasible. Injection through clothing and prior to skin cleaning is allowed if crew safety would be compromised. So essentially what this means is that if a person is violently agitated, etc., we're probably going to want to start with that 10 milligrams intramuscular or intranasal. I personally don't love the idea of chemically restraining a patient via the intranasal route, simply because by definition that means the patient is violent, and I really don't love the idea of getting my hands or fingers near someone's mouth who could bite me as part of their agitation. So I typically recommend going further out, whether it be the deltoid or the thigh, to be able to get this. If you've got someone that is so violent that it really is somewhat dangerous for you to approach them, then I would also not worry about trying to expose skin, etc. You can inject through the clothing into their leg and give them the medication, and then back off and let the police kind of back off as well until the patient begins to get sedated enough. When you can, after the person begins to become sedated, you want to get them on cardiac monitor, pulse ox, and end-tidal capnography. Try and get their oxygen level to above 95%. Check their blood glucose level when it's safe to do so. You should not ever leave this patient alone, since they are now under restraint, and so they need that one-on-one attention. You may end up needing to give them additional Versed, but in order to do so, you've got to call medical control to get that permission. Obviously, anybody that's receiving sedation has to be transported by a paramedic. So even if the police want to take the person, if they've been given sedation by EMS, we really need to discourage that and say, look, let us take them to the hospital. Since we've had to give them sedation, we need to monitor them. It's really recommended that you call ahead early to the emergency department you'll be transporting to, so that way the ER can get ready for the arrival of this patient that may still be violent and may still need sedation, or may need some sort of respiratory support. So I'd highly recommend calling them ahead early. So that concludes all of our discussion about Versed. We will be putting the Versed in the trucks in the coming days if it's not already there. We are also going to be printing off new versions of the pediatric quick sheets that have the volume of medication you need to draw up to get an equivalent dose to hopefully eliminate some of the math for you. And that'll go live in the truck the same day that the medication change does. Again, thanks for your time and attention, and good luck.